Alors, nous allons continuer avec une conférence du docteur Terry Harville. Je vous signale pour les gens qui veulent avoir la traduction simultanée, si vous avez un récepteur, à la position 1, c'est le français. Anglais? Alors, la position 1, c'est en anglais et la position 2, c'est en français. For the English-speaking people, if you want to listen to the conference, conferences in French, you can have the simultaneous translation by the channel 1. Are there any English-speaking people here besides Mr. Hardy? Okay, so you can have the direct translation in English of the French conférence, comme on dit ça en anglais, en tout cas, anyway, speeches, hein? Conf, OK. So, alors, je vais vous présenter maintenant le docteur Terry Harville. Do you understand a bit of French? So I can see whatever I want. Great. Okay. La conférence suivante sera présentée par le docteur Terry Harville, qui est à mes côtés. Le docteur Harville est allergologue, immunologue à Little Rock, en Arkansas. Il est affilié au centre médical UAMS pour University of Arkansas Service for Sciences. Alors, il a obtenu son diplôme de médecine du Collège de médecine de l'Université de Floride et il possède plus de 36 années d'expérience. Il se spécialise en immunologie clinique et possède une expertise et une expérience dans le domaine de l'asthme, de l'arthrite et du déficit immunitaire combiné sévère. Parmi ses intérêts cliniques et de recherche figurent les immunodéficiences, les maladies auto-immunes ainsi que la transplantation d'organes et de moelles osseuses. Nous sommes choyés de le recevoir. What I say that we're very pleased to have you here, Doctor. Il vient nous parler de la COVID longue chez le patient immunodéficient. Cette conférence sera présentée en anglais et comme je vous ai dit, mais ceux qui l'ont demandé ont accès à la traduction simultanée. Si vous en avez besoin et vous ne l'avez pas reçu, est-ce que c'est le cas? Est-ce qu'il y en a qui le veulent mais qui ne l'ont pas eu? Alors faites-nous signe, on vous en procurera. Alors très bien, tout le monde là. Alors accueillons Dr. Harville. Please, Mr. Harville. Welcome. No, go ahead, go ahead.
First, I apologize that I don't speak French. Thank you for the very kind introduction, and I really appreciate the invitation to come, and Martine and the Genovese and all that were involved in asking and having me come. This is actually quite an honor for me to be able to come here to speak. Since the presentation will be in English, afterwards, if there's anyone that's not clear about some of the things that I was trying to say or present, please find me and let's discuss it so I can help you understand better about what's going on. As you can see, I wear a mask because I'm still very concerned about the issues that we have with COVID. Let's see if I can make this work. Which? Green arrow. Green arrow? Ah, thank you. And so we're going to talk about long COVID. It goes by a variety of names: long COVID, long hauler, long haul COVID. The scientific name that most use is the post-acute sequelae of COVID-19, or PASI. And basically, what I will describe this as is a post-infectious immunoreactive disease. As we go through the talk, I'll be explaining further about what that's about. There are no financial issues related with this. There are no conflicts of interest involved. First, what I'd like to do is let you know a little bit about me. I'm an immunologist and rheumatologist and transplanter. And as you can see, that I was educated in the state of Florida and grew up in Florida. And indeed, this is a map of Florida, and the little red pointer shows where I grew up in a little town called Groveland in Florida. But I wanted to know more about where I was really from. And so I did one of the genetic studies, genealogy studies, and it says I'm from northern France. And indeed, although it's hard to say, and I don't think I have a pointer to show on the map, but near the middle of the map is the city of Harville, northeastern France. And as you can see also on the Arc de Triomphe, my name is present. Not me, but apparently I read that one of Napoleon's favorite generals was General Harville. And so I hope to find out more about this. And I'm hoping to relay that I feel that I'm actually French, even though I've never had the opportunity to learn to speak French, which is something that I need to do. Well, let's go further with going on with today's topic. This is a complex issue to deal with, and there's a lot of information that has been presented. When you read, there's a lot of information that is even contradictory. And so I'm going to try to go through and explain the items as I understand them and as it's made sense throughout this entire time period for the past few years. One of the problems from the standpoint of people with primary immune deficiency is we do not have a lot of clean data to know precisely what's going on. So we have to extrapolate and apply what is occurring from other studies to the general population of those that have immune deficiencies. And usually it works out reasonably well to extrapolate that way. For today's talk, I'm going to discuss the issue of why COVID is such a problem. Then, just as I've broken down here, this will be involving issues of evolution and in particular problems that autoimmunity that arise from this. And we'll talk about some of the broad autoimmunity, specifically discuss issues with anti-ACE2 antibodies, and then what are known as anti-idiotypic antibodies. Talk about some of the cytokine, chemokines, other immune modulators that are involved with the disease process. These are work that we've done in our studies to try to understand more than what's going on. And then I'll be moving from there into what is occurring with inflammation, the brain fog, which is one of the major problems that we see with people, and how chemokines are involved. We'll finally then define what long COVID is, discuss how we diagnose and treat, and summarize at the end. And so the question is why? Why is COVID such a problem? Why has this been an issue for the past 3 years? And basically why we've seen such devastation from it. And this has to do with evolution in our immune system. And so the bottom line is our immune system has been shaped over time by the pathogens that we've come in contact with. And over much of evolutionary time, humans lived in small groups of which the pathogens that were prevalent would either unfortunately kill off individuals that did not have immune protection, and those that had immune protection would survive. And this Darwinian process is what ended up shaping the way our immune system is and the way our immune system functions. And so we've had to deal with viruses in particular that primarily infect human beings, or that may be passed from other animals that are commonly in contact with human beings. And so that has allowed our immune system to know how to fight the viruses that are problematic for us. And so as you know, just a few years ago, in the 1980s, HIV became an issue. Again, a virus that had not been evolutionary constrained within humans and suddenly passed from other animals to humans has been very difficult. Other examples are, for example, Ebola coming from the apes into humans. Again, our immune system doesn't know how to handle those types of viruses. And the more we travel, the more the world's become connected. That's where these things are becoming more of an issue. And so the bottom line is our immune system doesn't know what to do with SARS-CoV-2 because it's not had to encounter it during evolutionary time. And so it makes mistakes. It becomes overactivated, and that overactivation creates a lot of the symptoms and problems that we see. And Unfortunately, because of this issue and the immune system misbehaving, we end up with issues of long COVID as a consequence. And so one of the problems with COVID that I was very concerned about is the target, and that's the ACE2 protein found on our surfaces of many of our cells in our body. And recognize that if you make an antibody to the viral target, which is called the RBD, or the receptor binding domain, that the immune system will make an antibody against the antibody, called an anti-atypic antibody, and that will then bind to ACE2 and disrupt ACE2 function. And so that was our hypothesis right the January of 2020, and we started testing for that. Now, during this time frame, others were looking for other problems, and Dr. Aaron Ring's group at Yale tested for thousands of potential autoantibodies and found that most patients after having COVID developed nearly 1,000 autoantibodies as a consequence of it. And amongst those, somewhere around 30 of those are specific for the CNS or the brain and affect the way the brain works. And so these are obviously a major issue and likely are also contributing to the features that we see with long COVID. One of the things, though, that I was surprised, and when I talked to Dr. Ring, is they didn't look for ACE2 antibodies, which is, again, what we had hypothesized to be an issue, and we did. And what we found was that patients that have COVID, and then if you check them again within a few months, you find that you generate a lot of ACE2 antibodies. And I don't have another marker, so I'm just going to point to help show what's going on here. The yellow dots represent the control subjects, and note that they've not made any antibodies against the receptor binding domain, which is the target that is utilized to neutralize COVID, and they've not made any ACE2 antibodies. In red, you'll see, oh, that's a pointer. Oh, thank you. Fantastic. And so in the red in this quadrant, you'll note that the patients that had COVID and are several months after having COVID had developed both the RBD, or the antibodies that are directed against the COVID, as well as the ACE2 antibodies. And patients that were very sick with COVID also tend to have developed the ACE2 antibodies early, again, demonstrating this autoimmune process starting to arise very early. And then when we tested the sera to see what will happen in a functional assay, we found that patients that were sick in the hospital with COVID, as well as those several months after having COVID, the antibodies against the ACE2 antibodies interfered with the function. And one of the other things that we noted was that patients that were not very sick seemed to have enhanced ACE2 function. Subsequently to our study, the Japanese reported that you'll make a type of anti-etiolopic antibody that carries out ACE2 function, so that you have these antibodies in your circulation that act as an ACE2 protein, which supports the data that we had generated quite a bit earlier. And so the point of this is that ACE2 is very important in regulating the blood pressure and inflammation in the body. And if you disrupt this function, you end up having problems with regulation of your blood pressure, so what we call dysautonomia, which can lead to a condition called POTS, postural orthostatic hypertension, and that it interferes with the ability to clear the inflammation that's occurring due to the COVID infection. And and we were the first to describe this process, and then we further need to help explain what's going on with anti-atypic antibodies that we published in the New England Journal of Medicine. And we'll explain now further what's going on there to help you understand, because this is the way the immune system works and the way we expect the immune system to function. And if you look at an antibody, that you have the functional end of the antibody that goes by a variety of names, antigen combining region, antibody combining region, variable region. This is the part that occurs by recombination of gene segments to produce the myriad, the large number of different antibodies that we have to fight all the different pathogens that we may come in contact with. We have another part here that's known as the constant region, FC portion. And this is also what defines an IgG molecule from an IgM molecule, from an IgA molecule, and so forth. And over on this side, you can see that there are light chains and then heavy chains that are shown in the blue. And so this is the way a typical antibody looks and what it's used for its function. Back in the 1970s, Niels Jern described this process that he called the network theory of the immune system. And it was based on the work that was being done in the 1960s regarding what's going on with antibodies. And he won the Nobel Prize for this in 1984. And to go over what the network theory is, you start with having an antibody. And again, you have those unique regions that define what that specific antibody is. And these, again, the variable region. And these will be unique for each antibody and for the and because they're new and unique for each antibody, they become a target for a new antibody to be produced because it's something, again, new to the body. And so these areas, again, are the ones that are unique, and these will create this antibody, and the antibody against these components will be slightly different than the original antibody. And so to see how this works, we start with the antibody that we call an idiotype, and then we produce an antibody against the antibody, and that's known as an anti-idiotype. And this is the way the immune system normally works and normally helps regulate itself and helps provide for our normal immune repertoire and for immune function. And so again, to help explain this, we have the idiotype, we develop the anti-idiotype, and then we have an anti-anti-idiotype. This antibody will be very similar to, but not quite the same as the original one. And so each one of these will have slight variations present. Now this can go on an ad infinitum process so that we end up now with an anti-idiotype that is very different from this original one. And so early in fetal development, this process is occurring to develop our immune repertoire. So once the antibody process starts generating, then each antibody that's generated acts as a target for new antibody production, and this then expands out, providing us for our normal immune repertoire. And so this is how we develop the antibody processes. And so this final antibody that we can generate can be extremely different from the original one, again, allowing us to develop a wide variety of antibody binding and production. And so to see how this is, conceptualize how this works, you start again with the idiotype antibody, they make the anti-idiotype, and then you just keep going on and on and on, making new antibodies that you can see that are interacting with each other almost like a wall or a fence to provide us with our immune protection. If we get infected or have an illness, we'll develop a hole in the repertoire where we have an antibody that goes missing. Our immune system senses this process, senses the loss of that antibody, and regenerates to fill in the hole, and that maintains our antibodies at a functional normal level. And so for us that have immune systems that work the way it's supposed to, this is the process occurring. When you have CVID, XLA, or other antibody deficiencies, this process doesn't work appropriately, and you don't generate the appropriate antibodies. And when you replace it with immunoglobulin replacement therapy, IVIG or sub-Q-IG, you're filling in all these gaps that are missing in the repertoire that you're generating due to your deficiency. And so now going on with explaining how this works with COVID, we start with having the spike protein from COVID, and where it will then bind to the ACE2 protein. And the binding area is called the receptor binding domain. And so this area is how COVID will bind to the ACE2, then be able to be transported into a cell to infect the cell. And so if we start again looking at the spike protein and where this RBD is, when you make a neutralizing antibody, or you're giving a vaccine to make the neutralizing antibody, the antibody will be made where it can bind to the RBD region. Well, this structure that's unique to be able to bind to that is going to be, again, a target for antibody production. And so you make the anti-idiotypic antibody that can bind to that. And so as you can imagine, for this antibody to bind to the same target, that it's going to look like the RBD. And so the anti-idiotypic antibody will mimic and look like the spike protein. And because you're generating that, it can then bind to the ACE2 and interfere with the way ACE2 functions. Because this creates autoimmunity, under normal circumstances, the immune system shuts this down. As you know, that you have to take the COVID vaccine every few months to get benefit from it. The reason for that is that once this process occurs, it shuts down the production of the RBD antibody, and then you lose the antibodies at a predicted rate of about half-life of about 3 to 4 weeks. And so your antibodies fall, and so within a few months, you have no more antibodies directed against the COVID. And so that's for individuals whose immune system is working the way it's supposed to be working, which is overall the majority of people. And this is, again, why you have to keep taking the COVID vaccine, because you lose your antibodies within a very short period of time. So moving further, we're going to talk about some of the cytokines and other immune factors that we found that's involved with the process. To orient you here is we've got 4 groups of subjects. The first group are individuals that were very sick with COVID in the hospital. The second group are those that had COVID but were outpatients that were not very ill. Our third group are people that are 3 to 4 months post having COVID infection. And then the fourth group are normal controls. And out of some 60 different cytokines, chemokines, growth factors, I'm just showing some representative ones that are very important in the process. And for example, this one is a chemokine called rantase, and note that it remains very elevated after having COVID. And indeed, what's interesting is it can distinguish itself because of the elevation from people that were initially ill with COVID or from controls. There have been a lot of publications recently where they're indicating differences in items like this, but when you look at the items, while they're statistically significant, for example, like these are actually statistically significant, but as you can see from the overlap, that you can't tell anything from the data for making a decision. Whereas because of the persistence of rantase being so elevated, I believe that it's a marker that can be of relevance for telling the difference between someone that is more severely ill with post-COVID type symptoms. So other ones just to mention are eotaxin, which is another chemokine similar to rantase that also for the most helps distinguish. Grimzyme B is a very good one for distinguishing those that are having persistent problems versus those that have not had problems. I won't go into what Grimzyme B is right now because that'll take too much time, but this is something important to consider. Then also interferon alpha is very elevated in people that are sick with COVID and also remains elevated in those who are having more of the post-COVID symptoms. So another group to look at are items such as IL-10. What's interesting about IL-10 is it is there to help downregulate the inflammation that's occurring. And so people that are very sick with COVID are generating a lot of IL-10 because they're trying to reduce the inflammation that's occurring during the illness. And it's also remaining elevated in the post-COVID state where trying to reduce the level of inflammation. Whereas people that were not very sick aren't having to produce very much of the IL-10 because they're not having the excessive inflammation that's occurring in those otherwise that are very ill. The IL-1 is also important in those that are sick and post-COVID. One of the things that you've probably heard about is the cytokine called IL-6. IL-6 is very elevated in the early phase of the very sick people and helps distinguish someone that is very sick with COVID from those that are not sick with COVID. But it's only useful in the acute phase. It has no benefit in post-COVID phase or in the long COVID. And then one of the ones that I'm very interested in, and I'll need to change my position so you can see, is called the IL-1 receptor antagonist. IL-1 receptor antagonist is also important for controlling inflammation. And note that it is very elevated in the post-COVID state. And it can distinguish people that have a significant ongoing inflammation from those that don't have inflammation post-COVID. And so we repeated some of these studies recently, and the bottom line is we're seeing the same items plus other ones that I didn't show you before. And so our new studies looking at people that are having ongoing long COVID neurologic symptoms have the same items present. For example, we're seeing the elevations in eotaxin and IL-1 receptor antagonists, the IL-10 that I was showing you in the previous slides. And these other ones are also elevated, creating problems. And I didn't show you the early data on that just for time constraints. And just to point out once again, the IL-1 receptor antagonists that we're seeing is the same levels that you see in people that have active severe rheumatoid arthritis, where it's trying to control the inflammation of the arthritis condition. Therefore, what we'd like to suggest and propose to you is that these are the issues that are occurring there as an ongoing process. They're resulting in the prolonged inflammation that we see with patients with long COVID, and it can affect a variety of tissues. And the brain is where we're doing most of our work, but you have the lungs, the heart, the GI tract, kidneys, and the pancreas. They're also heavily affected by these things. And so going with the brain fog is one of the major symptoms that people complain of due to having persistent problems after COVID. And what I'd like to point out is that we believe this is an issue with chemokines. And when the brain has injury, it releases chemokines to bring immune cells to the point of problem. And there's a lot of pictures here, but the point is that when you have the chemokines that are present, that they're attracting the immune cells to come into the brain to continue to result in inflammation. And even in the nose, where COVID can enter into the brain through the nerves that are present there, that you still have the same process occurring. And again, I don't want to make it overly complicated, but unfortunately these things are complicated. And there's a lot of things that are going on between the different components that are there. We'll narrow down to a few just to sort of mention and help illustrate. And so you have the astrocytes and the microglial cells, which act as immune cells within the brain. And they're cross-talking with such items as is pointing out in the previous slides, like the MCP1 and RANTES, and that these will also talk with the immune cells and then be talking with the neurons. And over here you can see also the IL-10 and so forth that are present. So we have these immune cells like the astrocytes talking with the microglial cells, and these are interacting with each other. And when they become reactive, then they end up resulting in injury to the neurons, and the neurons aren't functioning appropriately, and you end up with brain fog, and your thoughts aren't working correctly, your memory is failing, and you just can't think straight. And just again to illustrate this concept is that we have the microglia, the astrocytes, and the neurons, and the chemokines appear to be the major interactors because the chemokine receptors are present on the neurons, on the microglial cells, and the astrocytes. And these are probably the main things that are cross-talking back and forth between each other that are causing the neurons to not function appropriately. And so another aspect of the neurovascular injury has to do with microclotting. And so the researchers that were involved with this took brains and did brain dissection of individuals that had died either because of COVID or died from some other reason and had COVID. And what they found in all of these situations is that there were microclotting occurring, and that this situation appears to look like what we call myalgic encephalomyelitis chronic fatigue syndrome, which is a post-viral type of situation where your brain doesn't work as well and you end up with chronic fatigue. And with the biopsies, what they found with microvascular clots were found regardless of the severity. So someone could have very mild COVID and died due to a car accident, but still had a lot of microclots throughout the brain, which can lead, again, to the brain dysfunction. And what was interesting is they looked at our work and felt that the antibodies against the ACE2 receptors in the brain are primarily involved with this process and are helping to promote the microclotting that's occurring there, and that they are looking at a variety of processes there, including the microglial activation and how all these things, again, are injuring and damaging the neurons so they don't work as well as they're supposed to. So once again, this inflammation is occurring, and it's due to microvascular disease. You have the activation of the cells that are involved in the process, and the variety of cytokines and chemokines are involved, and the whole process looks like what we call ME-CSF. WHO has defined long COVID as a process where symptoms are persisting more than 3 months, and the symptoms consist of things such as fatigue, brain fog, having continuing lung problems, GI problems, cardiac problems. And most of the people that we deal with are having excessive prolonged fatigue and mental fog or brain fog. One of the problems hasn't been clearly worked out is how many people does this involve. Most studies show between 10 to 30% of people after COVID have some prolonged symptoms. Some may be minor, some may be more severe, but as high as 60% have occurred in certain age groups. And regarding the United States, this is a significant portion of the population that may be involved with this in the long run. And what people don't recognize or haven't realized is that this occurs in children, and as many as 10% of children that have had COVID are having prolonged symptoms. Indeed, this one study looked at a variety of symptoms and found that 78% of children had some kind of prolonged problem after having COVID. So COVID is not a benign disease in children. Again, the primary problems we've seen have been the brain fog and fatigue, and people complain of wearing out easily, having shortness of breath, and even when they're at rest. And so we have to come up with criteria for making a diagnosis. And so we diagnose COVID in patients that are at least 3 months after having had an initial diagnosis of COVID, and that they have the symptoms that we're discussing. And this is a clinical diagnosis. There's not a specific test that say you have long COVID. You look at the issues of having mental fog, fatigue, and perhaps some cardiac dysrhythmia, POTS, and these other features that appear to occur. Now, we're testing, laboratory-wise, we're testing for the issues of having autoimmune encephalopathy, and looking for the specific cytokines, chemokines that may be involved in this process. And those were some of the data that I was presenting to you earlier, where in November we're planning to try to organize all our data for publication, because we think that we can use those types of items to more critically and clinically make the diagnosis. In this one study, looking at veterans that only 35% of those that had post-COVID symptoms were resolved by 2 years. So nearly 2/3 of the people were continuing to have symptoms after 2 years of, so it goes away in some people, or appears to go away, but it doesn't go away in the majority. And as I was mentioning, we're also continuing to look at the role of the ACE2 antibodies in this process. And when you look at these slides later, if you want to go to our website, you can see more about what we're trying to do there. Now, one of the things we have to do is diagnose and then manage the process. And we perform a variety of tests to try to look at this. And so D-dimers fibrinogen, we think, are critical for testing because those look at the issues of the microclotting. And so we test those on everybody. And then we do some routine type testing, such as CBC, electrolytes, platelet count, LFTs, vitamin D levels. And then individually, we determine whether we suspect thyroid autoimmunity may be present. Frequently, we look at ANAs because ANAs typically become positive after COVID. Rheumatoid factors sometimes become positive. And so this autoimmune type screening we do depending on the symptomology patients have, and we'll look for celiac disease. Again, we've been doing this from the very beginning, looking for the clotting issue, and here's an article that had come out that indicated that D-dimer fibrinogen testing is very critical for trying to see if people are having microclotting problems. We always check the immunoglobulin levels because we want to make sure we don't miss someone that comes in that actually has primary immune deficiency that needs to be treated with immunoglobulin therapy. 2 patients at this point had unrecognized CVID that we diagnosed by doing their immunoglobulin studies and then did pre-post antibody studies that had come in because of having COVID symptoms. And we also tend to look for problems with Epstein-Barr virus because there's evidence that Epstein-Barr virus reactivates after having COVID infection, and that some of the chronic fatigue type symptoms may be due to the Epstein-Barr virus. And if we find elevations, we will give people medication to treat EBV. Depending on a variety of factors, again, how much autoimmunity we think that might be affecting the brain, we will check for neuronal antibodies and a special antibody panel called the Cunningham panel, where we can look for autoimmune antibodies that are directed against the brain tissue. Again, this helps us to know how much extra therapy we may need to be providing. And I'll mention later that some of these patients we've put on JAK inhibitors to try to deal with this. We will also check for lung function. We've checked EEGs in some patients we've suspected have developed seizure-like activity after COVID. And we use these types of studies, again, to help with our ultimate treatment options. Some of the other things that we do for trying to deal with this process is almost all the patients, we start with what's known as low-dose naltrexone. And this helps to cause a reduction in the inflammation of the microglial cells in the brain. And so usually once we start this, as well as celecoxib is another anti-inflammatory, that people will start having improvement in the brain fog. Their thoughts will start becoming more clear, and they will start having easier memory recall and feel like they can start functioning a little bit better, and their fatigue improves. Depending on issues, we sometimes will add doxycycline as an anti-metalloproteinase inhibitor because it reduces tissue inflammation, and so some of the arthritis-like symptoms people are having will improve. We tend to begin a stimulant also to help with the brain fog, and again, people have found this to be very helpful. And if the D-dimers fibrinogen are elevated, we begin medication apixaban, which acts as an anticoagulant, and people have told us that usually within 2 to 3 days of starting this, that they start feeling great again. they can start breathing more easily, and the brain fog goes away. And so we found that that is very helpful and useful for treatment. So we look at other things. If people are having hypertension or problems with their blood pressure control, we will tend to start what's known as ARB, or angiotensin receptor blockers. So these can help control the inflammation that's occurring due to the anti-ACE2 antibodies that are present. They're interfering with the ACE2 anti-inflammation function. We will also start antidepressants for those that are having more features of depression. And we tend to use the medication called fluoxamine, where there's been evidence that it has benefit for patients with COVID and long COVID. We, again, tend to use this to help reduce some of the features of disease that are occurring. And as I was just mentioning, we escalate to rheumatologic type therapies for those that are showing more evidence, stronger evidence of autoimmune encephalopathy due to autoimmune antibodies present. And we have a couple of patients where we've gone to JAK inhibitors to try to help deal with this, and suspect that over time that we may be needing to use more JAK inhibitors in these types of patients to control the autoimmune disease processes that are occurring. One of the things we recommend for everybody is take the vaccine, take the booster vaccine. And based on the data that I was showing earlier about the anti-idiotypic antibodies that are occurring, that what you want to do is try to regain control of the immune system. The vaccine, in particular, the Pfizer vaccine, but any of the mRNA vaccines can work, force the immune system to make antibodies against the RBD component. By doing so and redirecting the immunity directed towards the RBD, that when the ACE2 antibodies are starting to form, that it wants to shut off the process. And so this sort of globally helps to calm down the autoimmunity that's scattered throughout the body by refocusing it again to this to the singular component. And so we found that giving the booster vaccine can also greatly reduce the symptoms. And a publication came out recently suggesting that giving the vaccine to patients post-COVID is one way to get the long COVID symptoms under better control. And as I was mentioning, that this is based on the concepts that we developed on how the ACE2 antibodies are formed and how the immune system recognizes this as autoimmunity and then shuts down the process. And so if you can redirect strongly that immune direction, it can then regulate and control the inflammation that's occurring. We look at the lungs as needed, we look at the heart as needed, the GI tract is needed, and the kidneys is needed. And if we feel that we can't give the proper therapy for these things for an individual, we refer them to the pulmonologist, the nephrologist, cardiologist, to have them better treat the patients. But if it's something that we can control because it's not that severe, for example, for those that are having the lung problems, we'll start them on a Pulmicort inhaler, and that tends to provide them with benefit. Because diabetes is an issue, we monitor and check for issues there, and again, refer them to the endocrinologist if we think that they're developing diabetes, so they'll get the appropriate treatment for that. We look at the vitamin D levels, and we suggest that patients need to be taking 2,000 units of vitamin D a day, regardless of what's going on. If the vitamin D level is very low, we'll put them on higher doses. But vitamin D has been useful to help modulate the immunity and autoimmunity that's occurring with COVID, and suggests that 2,000 units twice a day. And again, we're not ignoring other tissues because they're not necessarily complaining of them. We try to sort through to make sure we're not missing something else in somebody. So we're trying to be comprehensive in our approach. So in summarizing the concepts and issues here, long COVID is not a singular process. It's a compilation of autoimmune diseases and that result as a result of a post-infectious inflammatory process in autoimmune disease where it has similar symptoms. You end up with the brain fog and fatigue as a couple of the major symptoms that can occur. There's been controversy with different articles, but overall, the severity of the COVID does not correlate well with the severity of the post-COVID. We've had patients that did not know they had COVID, and we were able to look at what's called a capsid antibody and showed that they did have COVID and have severe post-COVID. And we've had patients that have had severe COVID that just wanted to be checked out that only have mild post-COVID type symptoms. So the severity of the COVID doesn't really correlate very well. Things that we do know is if you're fully vaccinated, you're much less likely to develop COVID than people that were not vaccinated. And then once again, getting post-vaccinations after COVID help to regulate your autoantibody production so that you can help control the disease process. One of the things I mentioned at the beginning is we don't know a lot of the specifics that are occurring in patients with primary immune deficiencies because of the variety of primary immune deficiencies that are there. Some things that we can say is that patients that have the condition of XLA seem to have had very mild COVID cases and are at less risk for developing post-COVID. And the reason I would suggest that's the case is they don't develop autoantibodies. And whereas people that have CVID that can develop autoantibodies may be at higher risk for having some of the post-COVID features because of their propensity to develop autoantibodies. And our experience seems to fall out in this type of pattern. One of the things that is known is that some of the patients that develop what are known as anti-interferon autoantibodies have had worse COVID or passed away due to COVID. And so this is something that for patients that we know that have primary immune deficiency, we check to see if they have anti-interferon antibodies to verify that their risk factor for what's going to happen with COVID. The things that are still not clear but are suspected is that some people maintain the virus for a very long period of time. Indeed, patients that have primary immune deficiency may continue to have virus in their gastrointestinal tract that sheds and persists there for a very long period of time, even though their symptoms otherwise have gone away. And one of our concerns is that this can allow for the virus to potentially undergo mutations and alterations. And so there is concern about this is to generate new forms of the virus that may be more virulent than prior forms of the virus. The other thing is that this can be a source of continuing inflammation in some individuals. And so while they're not having the respiratory symptoms and fever of COVID, they can still be generating autoimmune inflammatory processes that are occurring throughout their body, causing body aches, causing joint aches, causing the brain fog that are occurring. And just reiterating that patients that have COVID can generate more than 1,000 different autoantibodies that can then result in problems with long COVID down the line, and that our concern are that people, for example, that have CVID that are at risk for developing autoantibodies may be some that have these things that persist much longer. And even over the years before COVID, dealt with a lot of patients that had ME/CSF type features, so chronic fatigue syndrome, that have CVID that were likely due to Epstein-Barr virus infection or some other viral infection as a post-infectious immune process. And because of COVID's effect on the immune system, there's concern about the reactivation of viruses that may be present in people, such as Epstein-Barr virus. And we also have found human herpes virus 6 being activated up in patients after having COVID, and that these then can start their own infectious cycle that add to the symptomology that's occurring. We think that evaluating for the anti-neural antibodies, the cytokines, these other processes are going to be ultimately the key to develop the appropriate therapeutic interventions. And so, as was mentioning, we're looking at these things now, and some of the severe patients, we've already started JAK inhibitor on them because of the presence of the autoimmune encephalopathy that we could diagnose through the finding of specific autoimmune antibodies directed against brain tissues. We suspect that some of the patients that we're going to be able to use IL-1 receptor antagonists that's used for patients that have arthritis to be helpful in patients. We haven't done that yet. Again, we're trying to put our data together where we can justify the use of these in those patients that have already have high levels of IL-1 receptor antagonists, because if you add further exogenous therapeutic medication, you can get some benefit as you do with patients that have rheumatoid arthritis. We always need to make sure we're not missing any of the other tissues that may be involved besides the brain, and make sure those are evaluated and treated as necessary. Again, I'm just reiterating some of the things that we've done, and we find that the anti-inflammatory medication with celecoxib and low-dose naltrexone can help a lot with reduction of the brain fog, and with the symptomology of inflammation throughout the body. The booster vaccine can be helpful, organ-specific treatment, and then trying to look at the cytokines, chemokines, and then the treatment as necessary for those. For example, medications like anakinra, which is IL-1 receptor antagonists, are safe to use in patients that have immune deficiencies. And so we're looking at this process as maybe a way to treat patients that have immune deficiencies versus a JAK inhibitor, which has immunosuppressive type properties. Yes. Yeah. Yeah, I'm almost finished. Okay. And so many people for the normal population believe that JAK inhibitors will be useful, and we found that also in a couple of patients at this point, that the continued process of vaccination to produce immune senescence of the autoantibodies may be helpful for patients that have immune deficiencies. And so a combination of these therapies are likely what are going to be required to individualize for the patient to get what they need done. And so finally, long COVID appears to be a post-infectious prolonged inflammatory process, which is similar to what we call ME/CSF or chronic fatigue syndrome. And using evaluation for a variety of factors, as I've been mentioning, can be helpful due to the fact that this virus did not co-evolve with their immune system. So we have to come up with ways to control what the immune system is doing adversely to deal with these things. And so obviously more studies are needed to help determine what is going to be our best treatment. And so I appreciate your attention for this, and willing to answer any questions that are involved. Thank you.
Good morning, Emmanuel Roux. I was wondering, do you think more frequent vaccination would be beneficial to long COVID patients, like more than the general population, because of the decline of the antibodies in the blood? So would it be better for them to receive more shots, more often?
And so the question is, should we be receiving the vaccine more often, especially if you have long COVID, or to prevent long COVID or prevent the problems? And yes, in my mind, we should be doing that. What the regulatory agencies are trying to, thinking of costs and other factors, are trying to lengthen out the time frame because of the, again, costs, but also there's a lot of anti-vaccine sentiment in populations, and so they're trying to prevent anti-vaccine fatigue, or vaccine fatigue. And immunologically, it would look to me like taking a vaccine every 3 to 6 months would be the way to help prevent problems. And for the patients that we have, that we've suggested to get revaccinated and then revaccinated. And so patients that have had a prior vaccination or have had COVID and are at least 8 weeks out and are having long COVID type symptoms, we try to get them vaccinated immediately. But we wait at least 8 weeks from the prior process to 12 weeks. We try not to go much more than 3 months because we think that that's an opportune time to try to re-regulate the immune system within 8 to 12 weeks.
Would it be every 3 months after?
I think that ideally that would be the case, but it's difficult for regulatory agencies and other physicians there's, as with many things, there's controversy. And in what we've done testing and what we've done in the understanding of the immune system and like Yerny's hypothesis and how the immune system works, we think that more frequent vaccination would provide more benefit. It's just, it's harder, some places it's hard for people to be able to go in and just get vaccinated. I know in the States that if you haven't, you have to be 3 months after your last vaccination before they'll allow you to be vaccinated again.
Thank you, Dr. Harville, for your help. I would like to tell the French people that they can ask in French and we can translate. Pour toutes les personnes qui parlent en français, gênez-vous pas pour poser vos questions. Martine et moi, on est là pour traduire à Dr. Harville du mieux qu'on peut. Donc, toute personne qui a des bonnes questions, c'est vraiment le temps de les poser parce que Dr. Harville, ça vaut la peine d'y poser des questions.
Hi, my name is Alice. I'm coming from north of Quebec. I have 2 questions. One personal question. I've been with syndrome immunitaire after I had many contact with the COVID. I am the first nurse who having Pfizer vaccine too. Everything was okay, but last summer, after my 3rd vaccine, I've been again in contact with COVID, with student nurse, and I didn't have a symptom, but I have a SPT, okay, and it's really rare in northern Quebec, nobody knows that. And me, I'm a bit afraid because every time I be back in contact with COVID patient, 1 month ago, I had again the COVID, and the pain re-begin where the first attack. So me, I'm really afraid to having back a vaccine of COVID because I'm afraid that activate the immunitaire attack. And in my country, nobody can answer. It said, oh, maybe not, maybe. So that's my first question.
Let me, so to understand that you had SVT after coming in contact with somebody with COVID?
Yeah.
And then did you also have symptoms of SVT after a vaccination?
No, really. I had a vaccine, and where's the attack been? It's where's my last place? I had the vaccine on the right shoulder, and after that, I have a vaccine. And 3 months after, when I've been in contact with somebody sick, me, I had the syndrome. But 1 month ago, I've been again in contact with COVID, the patient. I had a COVID, only snoozing, but the pain re-begin in my shoulder. It can begin to, but that's why I'm afraid to having a new vaccine, because I don't want to stimulate my system because they really attack me.
So So there's several things, and hopefully everybody will indulge me here while we try to explain what's going on. The vaccine, while you do produce some antibodies, the primary role of the vaccine is to generate T-cell immunity. And so the vaccine doesn't prevent you from becoming infected. What the vaccine does is help you, prevent you from having severe disease when you become infected. And so again, the antibodies persist for very little time and can't provide much protection because of the fact that they're just not there very long. And was the pain in exactly the same place that the injection was?
No, where's the injection? It was in the arm, in the deltoid, but the pain is in the plexus.
Up in the shoulder area?
Yeah, behind, because I'm paralyzed. By now I'm getting better, but...
So the pain, was it behind your shoulder?
Yep. Yep.
So there's what's called a bursa there.
Yeah.
And one of the things that happens with COVID infection is that people will develop bursitis from the infection. And have you ever injured your right shoulder before?
No.
No? It may be that you had the bursitis flare up as a consequence of that. The vaccine, the adverse effects of the vaccine are thought to be due to the polyethylene glycol that's present in the vaccine. And some people are very susceptible to having adverse reactions to that. It's very rare, but I've seen a couple of these patients. And usually the problem is having angioedema and urticaria. That's a major problem from the vaccine. People that have had any other adverse reaction to the vaccine, so like a lot of body aches or pain, subsequent vaccine injections, it tends to be milder each time. The people tend not to have a worsening problem from the vaccine. And it's hard to predict what would happen for you. But it may be that if you were to use your the left arm for the vaccine, that would less create stimulation over on the right side.
Okay.
It's can't predict for any one individual, but for the most part, people that have had symptoms like what you're describing, when they've been revaccinated, even some of our patients that were hesitant because of having severe problems in the arm that had been vaccinated, that when they got revaccinated, they did quite well. So you have to, unfortunately, you'll have to decide for yourself where to go regarding that. But I would suggest that you would wear a mask to make sure that you don't come in contact inadvertently again with somebody that can generate the heart-related problems.
Okay. Well, thank you. And my next question is, may you show us a few treatments for person who having COVID, and when the doctor will apply these things, because in north of Quebec, we have a lot of patients having that, nobody having treatment. Ventolin, cortisone, that TLC from the nurse, that's it.
And this is a huge dilemma, is that there's not any proposed therapies being made. It's all individual clinics like what we have developed our regimen that works for us, and that's what we recommend. And as I was mentioning, we're trying to put our data together in the next few months, where we'll publish our regimen of treatment. But I'm happy to speak with any physician that might be involved, and by email or however, and give them our recommendations for therapy that could be utilized. And so see me when we step down, I'll give you my card that you can take to the physician and contact about getting advice.
Thank you.
C'est pas grave. Okay, it's a silly question. It's just to know if it's possible to have high pressure after several weeks after having the vaccine for the COVID.
I'm sorry, I could not hear very well.
High.
Is it possible to have a high blood pressure as a consequence of vaccine? Several weeks after?
Okay, so having high blood pressure? After,
Several weeks after vaccine, is that possible?
So what can happen in the susceptible individual is the system that regulates blood pressure is called the renin-angiotensin pathway, where the kidneys send out a signal that to the heart that they need more blood flow to occur. And the ACE2 component that we've been discussing is one of the main regulators of this process. And so if you have downregulated the ACE2 function, then the body will go in and develop what we call dysautonomia, and in some people, the blood pressure can go up or actually go very low. And so you get this unregulated blood pressure that can occur. And usually when that happens from the vaccine, that it's relatively temporary until the immune system can re-regulate itself to shut down the autoantibodies that are causing this to occur. So generally, it's not very long-lived for people. And we've had people that have ended up with high blood pressure or low blood pressure, or up and down, and having what's known as postural hypertension occur because of that. And if I haven't answered what you need, please see me afterwards and we can talk in more detail. Thank you, and I'll be around if anyone wants to ask questions later.
Thank you very much, Dr. Harville.